Thank you for joining Cancer Support Community Atlanta for this program. Please visit our website, cscatlanta.org, for a complete list of live and recorded events. We invite you to sign up for our newsletter to stay connected to all future programs. Welcome everyone to today's program, High Risk and Breast Cancer. Today we'll focus on high risk and cancer genetics. I'm Katie Armsby with Cancer Support Community Atlanta. For those of you who are joining us for the first time, we welcome you and invite you to visit our website, cscatlanta.org. There you can see a complete list of the virtual and in-person oncology programs that are offered. We have some great support groups that are led by licensed mental health care professionals. I do want to highlight we have some breast cancer specific support groups that meet. We also have some stress reduction classes like yoga and Tai Chi, monthly nutrition seminars and cooking demonstrations, and then education programs like these. So again, you can visit our website right there, cscatlanta.org, where you can see a complete list of the virtual and in-person programs offered at no cost. I'm excited to welcome our program moderator to today's program. Emily has been kind enough to moderate a few of these programs for us, and we are happy to have her back. Emily Beard is the program coordinator overseeing breast cancer program development at Northside Hospital Cancer Institute. With a bachelor's degree in nursing from Emory and certifications in oncology nursing and breast cancer care, Emily has worked as a nurse navigator, patient advocate, and program coordinator. She has a special interest in metastatic breast cancer and developing initiatives for young people with cancer, specifically in the areas of hereditary cancer, fertility preservation, and sexuality and intimacy. Fertility preservation and sexuality and intimacy. So with that, welcome Emily, and I'll pass it off to you to begin today's presentation.
Thank you, Katie. Perseverance kind of goes along with preservation sometimes, so yeah, we'll take it. Well, I am really thrilled to be back. This series is really near and dear to my heart, both as a nurse and navigator, someone who's walked with lots of people through this cancer journey, but also as somebody who has a personal history, family history, I should say, a personal family history and personal high risk breast cancer kind of situation myself. So it's near and dear to my heart. And I'm really, really happy that we're doing this series. I think having a chance to, spread this out over 3 weeks and really kind of have a chance to hear from 3 experts. We heard from Kiana Olson last week, who's our nurse practitioner and coordinator for our new high-risk clinic here at Northside. And today we'll be hearing from Tim Hakim, who is one of our wonderful genetic counselors with so much knowledge and insight. So I'm going to go ahead and turn it over to Tim. I'm going to just quickly introduce him. He is a certified licensed genetic counselor. He sees patients with various family histories, as all of our genetic counselors do. His training was at the University of Arizona. His master's is in genetic counseling, and he's been with Northside for several years now, and we're so happy to have him on our team. So without further ado, Tim, I'm going to hand it over to you. And again, I'll just encourage folks to put comments in the chat. And as Tim wraps up, we'll begin a question answer period at the end. So feel free to put your questions in the chat, and we'll try to get to as many of those as we can. Thanks so much again for being here, and look forward to this conversation. Tim, handing it over to you.
Thanks for having me, Katie and Emily. As mentioned, this is part 2 of a 3-part series. Next week will be Savannah Duffy talking about nutrition. Last week was Kiana speaking about our high-risk clinic and risk reduction as it relates to breast cancer specifically, and talking about genetics, and in particular, hereditary cancer predisposition that may increase the risk for breast cancer. So I have a couple of objectives today to cover. First, I wanted to go over how genetics relates to cancer in general and breast cancer in particular, and then move on to describing some of the common things that could be found from an inherited perspective or hereditary perspective, common hereditary cancer predisposition syndromes, and then really talk about how genetic testing can impact medical management, both for people that have been affected with breast cancer themselves, as well as for family members. So I wanted to start off just by defining a couple of terms that oftentimes get thrown around or used interchangeably, but in cancer genetics, we think of these three terms, genetic, hereditary, and familial, a little bit differently. So, so in terms of being genetic, all cancer is genetic, and by that we mean that it's caused by changes or mutations that happen in our genes. So genes are the instructions that tell our cells how to grow and function, how to not grow out of control. So we get, when someone has cancer that develops, it's because there's been changes or mutations that have happened in individual cells that have caused those cells to misbehave, to grow out of control, and not do what they're supposed to be doing. So our genes are inherited from our parents, but the mutations that can cause cancer are things that happen over someone's lifetime. And that can happen for a lot of different reasons, particular exposures, like chemicals, sometimes viruses. We think of skin cancer as being very much associated with sun exposure and UV radiation, lung cancer being very strongly associated with smoking, things that can cause mutations in the lung cells and skin cells. But oftentimes too, mutations can just happen randomly. So it's not that someone has done anything wrong. Mutations happen all the time for all sorts of different reasons, even just cells dividing or just normal cell functions can accidentally cause mutations to happen. So because of that, we have certain genes that their job is to keep us from getting cancer. And that's where someone can have an inherited predisposition. So when we speak of hereditary cancer, what we mean by that is a cancer predisposition, so something that someone is born with, something that could be passed on from generation to generation, typically caused by an inherited mutation in one single gene that can be detected with current genetic testing. So like I mentioned, mutations are very common to happen over someone's lifetime that can cause cancer. The genes that we think of as cancer predisposition genes, really their job is to prevent cancer. And they do that by fixing the mutations that happen randomly over someone's lifetime so that they don't develop cancer. So you can think of these as anti-cancer genes or DNA repair genes or anti-tumor genes. So if someone inherits a mutation or a broken copy of one of these anti-cancer genes, then that can result in a higher cancer risks over their lifetime. So different genes or mutations in different genes can have varying types of cancer risk. So there's some genes that have higher risk for breast cancer or ovarian cancer. Other genes may have a higher risk for colon and uterine cancer. So there's different profiles of cancer risks that we can see with different genes. And then there's also different degrees of risk with different genes, whereas for some genes may have maybe a 20 to 30% lifetime risk for a woman to develop breast cancer. Other genes may have about a 70% lifetime risk for breast cancer. So not all genetic predisposition, hereditary predisposition syndromes are the same. Some of the most common hereditary breast cancer genes include BRCA1 and BRCA2, or BRCA1, BRCA2, as well as CHEK2 and ATM. The latter two, a lot of times people haven't heard of, but are actually even more common than BRCA1 and BRCA2. So then the third term is familial. So what we mean by that is a pattern of cancer in a family that in the absence of any identifiable genetic mutation. And this is pretty common. This is very common that someone will have a family pattern of cancer, but there's nothing that we find when we do genetic testing. So we think that this could be due to maybe shared environment or similar lifestyle risk factors between people in the family. There could be other genetic risks that we just don't know about or don't know how to test for with our current genetic testing. And less than half of family history of breast cancer can be explained by an identifiable inherited gene mutation, or what we would call hereditary cancer. So that's a good chunk of people that have a family history of breast cancer but don't have anything that can be found with genetic testing. So what we know of in general is that if there is a family history of breast cancer, that can increase the risk for relatives to also develop breast cancer at some point over their lifetime for whatever reason. We may not oftentimes know what's causing that higher risk. We just know that there's an association there. Or if we look at women who have had breast cancer, then their relatives have a higher risk of having breast cancer as well. So one study tried to quantify that, and for a first-degree relative, if you have a first-degree relative, which would be a mom or a sister or a daughter, in some cases even a father or brother. Anyway, if there's a first-degree relative, it's about a 53% increased risk for breast cancer. So the general population risk for breast cancer is about 13%. So if you have a 50% increase in risk, that would take someone up to close to a 20% lifetime risk for breast cancer. Also, I'd like to point out that 13% lifetime risk for breast cancer is really, what we would quote for someone who's young, who's maybe 20 or 25 and has presumably a long lifetime of many decades ahead of them. Whereas if you are 70 years old and you have a sister or a mom with breast cancer, your remaining lifetime risk is still higher than a 70-year-old who doesn't have that family history, but it's going to be a much smaller absolute remaining risk. That risk is higher if the family member with breast cancer had it at an earlier age, particularly if they had it before the age of 40. And then there can be a slightly increased risk when you have a second or third degree relative with breast cancer, like a grandmother or aunt or cousin. But that's a smaller increase in risk for breast cancer. Of course, then the number of women with breast cancer in the family also makes a difference. But also in all of this, it's important to consider the size of the family, especially the number of women. So if you have one sister or no sisters, and your mom had only brothers, no sisters, and your father didn't have any sisters, then there's a limited number of women in the family. So to have a single woman with breast cancer in the family might be more significant than if you have one aunt out of 10 aunts that has had breast cancer. That may not be as worrisome or significant. So we kind of take with a grain of salt, so to speak, the amount or number of people with breast cancer in the family. So if someone has a family history of breast cancer, does that mean that it is inherited? And so hopefully at this point you could answer that no, based on my prior explanations of this. But less than half of family history of breast cancer seems to be explained by an identifiable inherited gene mutation in a family. There are 13 different genes that we know of that are associated with predisposition to breast cancer, meaning that if someone has an inherited mutation in one of those 13 genes, they have a higher risk for breast cancer. And genetic testing allows us to look for mutations in those genes. So when we look at people who have cancer, it's only about 10 to 15% of people who have an inherited predisposition. It varies a little bit from cancer type to cancer type, but it's probably about 10% of women who have breast cancer that have an inherited predisposition that can be found with current genetic testing. Maybe another 15 to 20% of the time that there's a family pattern of cancer. But really most cancer and most breast cancer is what we call sporadic or isolated, meaning it's happening in people who don't have a close family history of breast cancer. So some of the things that are clues for us when trying to assess if someone may have an inherited predisposition, if there's hereditary cancer in the family, is if we see people with cancer at young ages, so we say under the age of 50, but that's not an absolute, and it is a little bit relative. So if you have someone with breast cancer or other cancer, at 35, that would be more suspicious than if we saw someone with breast cancer at 48 or 49. And then when we see multiple people with the same or similar kinds of cancers, so as it relates to breast cancer, we also look to see if there's other cases of ovarian or pancreatic or prostate cancer in the same family, or sometimes the same person with ovarian and breast cancer. And then also if we see bilateral breast cancer, or breast cancer in both breasts, or multiple primary breast cancers, where someone has had breast cancer, even if it's in the same breast, and it appears that it's a second new breast cancer that's developing years later. Also, if we see multiple generations affected, like grandparents, siblings, and children, that can be an indication of an inherited predisposition. Male breast cancer is a big red flag, as well as Ashkenazi Jewish ancestry, which I'll explain a little bit more about on the next slide. So what are some of the things that can be found when doing genetic testing? So probably the two genes related to breast cancer that get the most attention are BRCA1 and BRCA2, or BRCA1 and BRCA2. And they're associated with an increased risk for not just breast cancer, but also ovarian, prostate, pancreatic, and other cancers as well. So it's about 3% of women with breast cancer who have a BRCA1 or BRCA2 mutation. That statistic kind of changes depending on the source. And then if you're looking in the general population, it's only about 1 in 300 people just in the general population that has a mutation in either BRCA1 or BRCA2. But that goes up quite a bit when looking at the Ashkenazi Jewish population, or specifically, or people who have Ashkenazi Jewish ancestry. And in that population, it's more about 1 in 40. And then most of the genetic testing that was done through about 2013 was only looking at these two genes, BRCA1 and BRCA2, for several reasons, not least of which there was a single company that had a patent on sequencing BRCA1 and BRCA2, and they lost that patent in 2013. And so soon after that, there was a lot more companies that entered and a lot more competition, and labs started offering a lot more testing for a lot more genes simultaneously. I tell people that BRCA1 and 2 have about a 70% lifetime risk for breast cancer for women. There's also a significant increased risk for having a second breast cancer in the future. So the 20-year risk is about 40% with BRCA1 and 26% with BRCA2. There's also an increased risk for male breast cancer, especially with BRCA2. Ovarian cancer risk is significant. It's about 50% with BRCA1 and about 25% with BRCA2. Prostate cancer risk is also increased with these genes, especially for BRCA2. And you can see that there's a pretty wide range there of 19 to 61% lifetime risk for prostate cancer. Depends on the study that's being looked at, but some studies have shown that through about age 70, the risk is maybe more like 25 to 30% lifetime risk for prostate cancer. And then after age 70, like through age 80, that risk starts going up a lot, approaching 60%. Also, men who have a BRCA1 or 2 mutation also tend to have more aggressive prostate cancer. So if we see men that have metastatic prostate cancer, and or are passing away from prostate cancer, especially if they were seeking treatment, then that can be a clue of an inherited predisposition as it relates to not just prostate cancer, but breast cancer. And then lastly, there's a increased risk for pancreatic cancer with both of these two genes. There's another gene that I just wanted to highlight briefly called palpitude, and it is an abbreviation for partner and localizer of BRCA2. So I call it BRCA2's little helper. And it also has an increased risk of breast, ovarian, and pancreatic cancer, not quite as high as BRCA1 or 2, but about a 50% lifetime risk for breast cancer in women. And we think a significant risk for having a second breast cancer as well as some of the other things that we see with BRCA genes, ovarian, pancreatic, and prostate cancer. So it's about half of 1%, or 1 in 200 women with breast cancer who have a PALB2 mutation. That's actually higher in the African American population, which is one of the reasons I wanted to highlight it, especially given our population here in Atlanta. So it's about 1% of the African American population who carries, women with breast cancer who has a PALB2 mutation. In the general population, it's much less common, about 1 in 850 people just at random has a PALB2 mutation. So most of those 13 genes that have a higher risk for breast cancer are what we call moderate risk genes. So these are things that have a 20 to 40% lifetime risk for a woman to develop breast cancer if she has an inherited mutation in one of these genes. The two most common of those are called CHEK2 and ATM. And they each have about a 1%, about 1% of women with breast cancer will have a CHEK2 mutation, and about 1% will have a ATM mutation, inherited mutation. It's more like about 1% of the general population has a CHEK2 or ATM mutation. So somewhat common. You almost certainly know someone who has a CHEK2 or ATM mutation, and probably know several people that have a mutation in one of those two genes. And then overall, there's about, looking at some of the other moderate risk genes, it's about 1 in 300 women with breast cancer who have a mutation in one of the other moderate risk breast cancer genes, like BARD1, RAPID1C, RAPID1D. And those genes also have about a 20 to 30% lifetime risk for breast cancer. There can be slightly increased risks for other kinds of cancers with these genes, like ovarian cancer and pancreatic cancer, but mostly the risk is for breast cancer. So conceptually, I like to think of these in 3 different categories, or put people in 1 of 3 different categories in terms of risk. So you have people that just in the general population, the general population risk for breast cancer is about 13%, or about 1 in 8 women will develop breast cancer just by chance through age 75. When people have an inherited mutation in one of those moderate risk genes, it increases that risk maybe 2 to 3-fold, into the 20 to 40% range, which is a significant increase in risk, but it's still less than 50%, meaning that it's more likely for a woman who has a mutation in one of these moderate risk genes not to get breast cancer than it is for them to get breast cancer. When looking at someone's family history, then, it's not at all uncommon for someone to have a CHEK2 mutation, and they might be the first woman with breast cancer in the family, or it's not particularly suggestive when you first look at it of an inherited predisposition. And then you have some of the high-risk genes, particularly BRCA1, BRCA2, PALB2. There's a couple of other genes that also have much higher risks in the 50 to 70% range for lifetime risk for female breast cancer. And where someone falls in terms of the risk also changes some of the medical management guidelines. There's also, as I mentioned, higher risks for a second new breast cancer when someone has an inherited predisposition, particularly with BRCA1 and BRCA2, the higher risk genes. So I mentioned earlier that overall the 20-year risk for a second breast cancer with BRCA1 is about 40%. With BRCA2, it's about 26%. And when looking at women who are premenopausal when they've had their first breast cancer, it's even higher. So the concern is not just about recurrence, like we would be concerned about with any woman with breast cancer, any one with cancer in general, but the thinking about the risk for having a second new breast cancer that develops. So knowing an hereditary predisposition in a person or family can really be important for changing medical management. For the person who has cancer, it can inform surgery decisions. So a lot of times that's the pressing issue that we're trying to decide for someone who has breast cancer is if they, if all other things being equal, if they are eligible for doing breast conservation, of doing a lumpectomy, versus if there's a hereditary predisposition like a BRCA1 or 2 mutation, it's recommended to consider doing a bilateral mastectomy, not just to treat the current breast cancer, but to prevent having a new breast cancer in the future, a second new breast cancer in the future. There's also certain targeted treatments that people are eligible for, particularly if they have an inherited BRCA1, BRCA2, or palpitude mutation. Those drugs are called PARP inhibitors. And then also for the person who has cancer, knowing that there's a hereditary predisposition tells us if there's increased risk for other kinds of cancers, like a second breast cancer, ovarian cancer, pancreatic cancer, et cetera. For family members, knowing that there's a hereditary predisposition can be really useful to change screening. And that's really the best use, I think. I don't want to say the best use, but a really great benefit of genetic testing is if we know that there's a specific hereditary predisposition in the family, we can identify those people, those women who do have a higher risk, then we can proactively start offering them breast screening earlier. So as early as age 25 with BRCA2, it's recommended to start doing breast MRIs. It's also recommended with both the moderate and high risk genes to do breast screening every 6 months, once with MRI and 6 months later with mammogram, so alternating back and forth between those two. And particularly for younger women, breast MRI can be helpful because younger women tend to have denser breast tissue, and so breast MRIs are better at finding early breast cancers in women who have denser breast tissue, better than mammograms, or better than mammograms alone. Also, knowing there's a hereditary predisposition can inform preventative surgeries, like preventative bilateral mastectomy or preventative removal of ovaries for those who have a higher risk for ovarian cancer. And also it can change, sometimes that changes people's life decisions as well. When to have children or et cetera. So, and then for both those with cancer and those unaffected family members, knowing that there's a hereditary predisposition allows a lot of proactive prevention, like lifestyle modification, changes to diet, chemo preventions, which are a lot of the things that Kiana does with our high-risk clinic and Savannah does as a dietitian in our high-risk clinic. So kind of talked through this, but this is just a visual explanation of putting people in one of three groups. Those who have an average risk for breast cancer, it's recommended to do annual mammograms starting at age 40. When there's an increased risk, either due to an inherited predisposition or, importantly, if based on a risk model that's taking into account personal history, risk factors, as well as family history, if a risk model estimates that someone's remaining lifetime risk for breast cancer is greater than 20%, they also would be recommended to have increased screening with breast MRIs and annual mammograms, alternating every 6 months. For those who, and that screening can start as early as age 30 when there's an inherited mutation and or 10 years before the earliest breast cancer in the family. With BRCA1, BRCA2, PALB2, it's recommended to do that same screening every 6 months. It starts even earlier, particularly with with BRCA1, BRCA2, with MRIs. The biggest difference then is that with the high-risk genes, it's recommended to consider doing risk-reducing bilateral mastectomy. That's obviously a very personal decision, and it depends on lots of other factors, like the person's age and other health issues, but it's something to consider. And then also, because there's a significantly increased risk for ovarian cancer, it's recommended, and this is even a stronger recommendation. It's not a recommendation to consider removal of ovaries. It's just recommended to have ovaries removed once someone's done having children. So with BRCA1, typically 35 to 40. With BRCA2, it's reasonable to delay that a little bit longer until 40 to 45. So when should genetic testing be considered? So these are the guidelines from the NCCN, or National Comprehensive Cancer Network. This is a lot of information, so I'll try to go through it quickly, but also highlight maybe the more important things and the more common things. So anytime that there's breast cancer under the age of 50 or younger, it's recommended to do genetic testing. Also, I'm going to just jump down to, sorry, I realized I wasn't advancing my slides properly, but also, if there are 3 or more cases of breast cancer in a family, so the patient plus 2 other people with breast and or prostate cancer, then it's recommended to do genetic testing to look for an inherited predisposition. And then some of the other things that can be an indicator or a reason for doing genetic testing are if there's any ovarian cancer in the family, triple negative breast cancer, regardless of age, male breast cancer, if someone has had bilateral breast cancer in both breasts or 2 primary breast cancers. And then, of course, if there's a known mutation in the family, and then also if there's been prior genetic testing that was only looking at BRCA1 and 2, then it's recommended to do updated testing that looks beyond BRCA1 and 2. Typically, that's going to be for people who had genetic testing in 2013 and before, but it kind of depends on what testing was done for those people who have testing maybe 2014, 2015, 2016. Just kind of depends on what was done specifically. Also, anyone who has a first or second degree relative with breast cancer that meets any of these criteria, they meet criteria for having genetic testing themselves. So if you have a grandmother who had breast cancer at 45, for example, then you would meet the criteria for recommending genetic testing. However, that leads into the next thing, which is really who should consider genetic testing. So ideally, ideally, you would test the most informative person in the family first, if possible. So if there's a grandmother who had early breast cancer, and that's kind of the most suspicious person, testing her first would be the most informative. Or if it's a mom with breast cancer, testing her first would be the most informative. So whenever possible, we want to test the person who has had breast cancer or ovarian cancer as well, just to see if there was a hereditary predisposition that they have. Because if the person with breast cancer that we're concerned about, if they don't have an inherited predisposition, at least nothing that can be found with genetic testing, then we're not going to expect anything to be found if we do genetic testing on the unaffected person in their child or grandchild, for that matter. So you can't pass on what you don't have. So if an unaffected relative tests first, and we don't know if there wasn't, if an unaffected relative tests first and we don't find anything in that unaffected person, we don't know if that negative result is because there was something in the family that just wasn't passed on to them, or if there was just nothing to be inherited to begin with. And that affects our risk assessment for that unaffected person. When the affected relative isn't available for genetic testing. So let's say that grandmother has passed away, or there's an aunt who had breast cancer, but they've passed away. Then testing in the case of a maternal aunt, and testing someone's mother first would be more informative, because again, if the aunt had something, then it's a 50% chance for that to be shared with someone's mom. And then if the mom had it, it's a 50% chance of that being passed on to their children. So testing mom first would be helpful to see if there was something that could be passed on to their child. That also is true, though, for if there's a maternal family history of breast cancer or ovarian cancer. That if there's a paternal aunt that had breast or ovarian cancer, or a paternal grandmother, and they're not available to do genetic testing, either because they've passed away or don't want to do it, or live in another country or something, then if possible, testing the father would be more informative than going straight to the unaffected, usually younger generation. And then, of course, if the parent tests negative, then generally we would say that the child does not need to do genetic testing unless there's something on the other side of the family to be concerned about. That also can be more efficient in terms of if there's a parent that you can test and they have multiple children, testing the parent may eliminate the need to test all of their children. It gives us a more clear-cut answer. So putting this just into an example of practice. So this is what we call on the left, we call this a pedigree or family tree. Circles are females and squares are males. So I have a hypothetical person, Kimberly, who's a 26-year-old female. She has a strong family history of breast and ovarian cancer on her dad's side of the family, with her aunt having ovarian cancer very recently at age 58, her other maternal aunt having breast cancer about 10 years ago at 37, and maternal grandmother having breast cancer at 60. There's also a maternal grandmother with breast cancer at 52, so kind of on the youngerish side, which is not my best perfect example, but because there's breast cancer on both sides of the family, but honestly, that's how family histories usually look, because breast cancer is common enough that it's pretty rare that there's not at least someone with breast cancer in the family. So I just added, for argument purposes, that this maternal grandmother, is the only sibling with any kind of cancer, and she has 5 sisters and 5 brothers, and all of them lived into their 70s and 80s. So in other words, we wouldn't be too suspicious of that lone case of breast cancer on the mom's side, but we would be on dad's side of the family. So when we do a risk assessment on this person, there's various risk models that will estimate someone's remaining lifetime risk for breast cancer. So for a 26-year-old, this is going to be basically the whole life, because they're still very young, but this would go down as someone gets older. The model that I typically look at is the Tyrer-Cuzick version 8, and it estimates that this person has a 24% remaining lifetime risk for breast cancer based on her family history and personal risk factors, and also about a 9% lifetime risk for ovarian cancer. This model estimates that there's a 16% chance of the person having a BRCA1 or 2 mutation. Based on this, it's recommended to do annual breast MRIs because their risk estimate is over 20%, and it's recommended to do it now at age 26 because the maternal aunt had breast cancer at 36, so 10 years earlier. But risk-reducing surgery would not be recommended for this person in this example. So ideally, what we would do is we would recommend testing the patient's maternal aunts who've been affected with either breast or ovarian cancer, or second best would be testing the father. But let's say that this person was not in contact with their aunts or their other relatives, didn't want to do genetic testing. If this person had negative genetic testing, it would drop their estimated breast cancer risk slightly. So we'd be eliminating a hereditary predisposition that the person has, but we wouldn't necessarily know if that breast and ovarian cancer on the paternal side of the family, if that was maybe still due to an inherited predisposition that just didn't get passed on. So the risk models tend to still estimate someone's risk as being elevated because we don't know what was causing that breast and ovarian cancer in the family. So essentially, genetic testing for this person isn't going to change anything in terms of their recommended management because they're still over 20%. They still would be recommended to have annual breast MRIs. There's no recommendations for risk-reducing surgery, and it's recommended for them to have their aunts and father tested, and also siblings. We know nothing, just because this patient has tested negative doesn't mean that there couldn't have been something that their father has that could be passed on to their siblings. Now, if this person was to test positive for a BRCA2 mutation, then obviously their risk is going to go way up, and that will make some differences to their medical management. So their estimated breast cancer risk is going to go from about 24% to 72%. Their estimated risk for ovarian cancer is going to go up to about 30%. And then at this point, then it would be recommended to do or to consider risk-reducing bilateral mastectomy. It would also be recommended to have ovaries removed when this person is probably 40 to 45. And it also would mean that there's a 50% chance for each of her children to have this same BRCA2 mutation, and also for each of their siblings. Now, kind of the ideal situation, in terms of the patient's risk, is that if one of their aunts and or father was found to have a BRCA2 mutation, this same BRCA2 mutation, and then the patient tested negative, meaning they don't have the BRCA2 mutation, then their remaining lifetime risk, their estimated lifetime risk for breast cancer would drop down to about 19%. And it would drop down even further if they didn't have that maternal grandmother with breast cancer. So at this point, with this level of risk, they basically just be recommended to have general population screening, which would mean annual mammograms starting at age 40. So we would call this a true negative because we know what's causing the breast and ovarian cancer in the aunts, and likely the maternal grandmother with breast cancer, and the patient doesn't have it. So just briefly, what does a genetic counseling appointment involve? It would typically we'll go over someone's personal family history of cancer, draw out a pedigree, do a risk assessment, and try to give some idea of do they meet criteria for recommending genetic testing, how suggestive, more subjectively, how suggestive is their family history for a hereditary cancer predisposition, discuss genetic testing, including benefits and risks, and then post-test, we would go over the test results with them and management implications for the patient and family. So really, I wanted to end on a more positive note and say that knowledge is power, that your family history is not your destiny. We talk about risks and about numbers of risk, but even when there's what we call even when someone has a very high risk, like a BRCA mutation that has a 70% lifetime risk of breast cancer, that still means that there's a 30% chance of not having breast cancer. And it also is assuming that there's not interventions, there's not preventative surgeries for chemo prevention, other things. So there's a lot that can be done, even with an inherited cancer predisposition. There's a lot that can be done to reduce risk. And so for those who have even a very high inherited risk, like a BRCA mutation, the life expectancy for those people is basically the same as someone who does not, assuming that they're doing recommended screenings and or preventative surgeries. So at this point, I'm going to hand it back over to Emily. Please you can put your questions into the chat. Yeah.
Okay, sorry, I was trying to unmute there. Thank you, Tim, so much. That was awesome. I think I know a lot about genetics, and then I sit and listen to you and I learn so much more. So thank you. We did have one question. I think it was a clarification perhaps on early on one of the slides. You had talked about a risk of second breast cancer. And so we're just asking, are you referring to metastatic or a completely different type of cancer? I did kind of just quickly in the chat say that I would have you address it, but I think what you're talking about when you talk about a second breast cancer is a second separate occurrence of breast cancer, like a breast cancer that would either be in the other breast or potentially a breast cancer that would be a second breast cancer in the breast that was originally affected, or depending on the gene, another cancer. So somebody that might have a new ovarian cancer, or somebody that might have a new pancreatic tumor or something like that. Is that right?
Correct. Yeah. So second primary cancer.
Okay.
Yeah. With breast cancer, usually it's a little easier if you know that it's in the opposite breast, and you can almost assume that it's a second primary breast cancer. But it could be in the same breast, a second new breast cancer. The way I like to think of it too is that when someone has breast cancer, the first time, their doctors are doing everything they can to prevent them from having a recurrence. So through some combination of surgery, radiation, chemo, etc.
Right.
And if the goal is to eliminate 100.000% of all the cancer cells, but if you could do that, and know for certain that you've done that, what is the chance of having a second new breast cancer, a second new cell that goes awry and creates a new breast cancer?
Okay, that makes sense. So I have a question somewhat related to that. So we had gotten this question ahead of this presentation, but this is about somebody who has a family history of ovarian cancer. So I don't know the specifics, but someone with ovarian cancer in their family history, are they at higher risk for a BRCA mutation? And what would their sort of next step be if you have that family history of ovarian cancer? How would you want to follow up with that?
Yeah, so that's a great question. So ovarian cancer is one of the types of cancer that has a higher chance of being hereditary, meaning it's about 20 to 25% of people that have ovarian cancer that have some sort of inherited predisposition. It's about 10 to 15% of women with ovarian cancer have a BRCA1 or BRCA2 mutation. So that's most of that 20 to 25% is BRCA1 or BRCA2 specifically. There's other genes that can have a hereditary predisposition, including things actually outside of breast cancer related more to colon and uterine cancer, something called Lynch syndrome. So if possible, the best person to test would be the person who's had ovarian cancer. Unfortunately, that's oftentimes not possible. So the next best would be the next closest person, or if you're talking about an aunt or grandmother, then the parent on that side of the family, they can have testing. That would be ideal. But anyone with a family history of a first or second degree relative with ovarian cancer meets the criteria for recommending genetic testing. So they could do genetic testing. If there is a mutation in the family, the chance of it being shared with a first degree relative, so parent or sibling, is 50%. Chance of it being shared with a second degree relative is 25%. So yeah.
That's great. Thank you so much. So another question from one of our participants asking about specifically diet, exercise, and the word chemo prevention. Can you explain those terms? I mean, I think we know what diet and exercise, but can you explain chemo prevention and then also talk about how diet, exercise, and using medications like tamoxifen, for example, would be beneficial to somebody who might be at high risk?
Yeah, so those I can briefly talk about those, but also defer to Savannah and Kiana, who are more experts in that. So in terms of the diet, yeah, Savannah can talk much more about that next week. Diet can impact, have effects on the risks for breast cancer, as well as BMI, or body mass index, is associated with a higher BMI, is a higher risk for breast cancer. Somewhat, and exercise can lower, regular exercise can lower your risks. I always like to be careful too that we don't, in talking about all of that, we don't blame women for their breast cancer. A lot of times this happens with hormone replacement therapy. So yes, a lot of these risk factors do increase, or conversely can decrease someone's risk, but they are, each small things that maybe change, percentage point or two, they're not huge changes. And the chemo prevention is, you mentioned tamoxifen. So there are drugs that basically block estrogen and progesterone. And we know most breast cancers, not all, but most breast cancers are fed and driven by estrogen and progesterone. So the idea is that chemo prevention is by having a drug that suppresses those hormones, it can reduce the risk for breast cancer quite considerably. I believe it's for women who have BRCA mutation, I believe it's about a 50% reduction of breast cancer risk. So pretty impressive.
Yeah. Yeah, I think it's just such a fascinating discussion. I think next week's conversation with Savannah will be really helpful in terms of really getting to like, what can I do? Because a lot of this can be, you're sort of stuck with your genes, right? The genes are stout, like you're not changing that risk, but there are some things you can do to mitigate that risk, with lifestyle changes. So I think that's the take home. We had a question about insurance. What is the landscape, or what does it look like in terms of insurance? How do I, know whether my genetic testing would be covered by insurance? And of course, it always depends on what that insurance plan is, but can you talk a little bit about insurance coverage and how you go about getting patients access, maybe who don't have insurance, or don't want to use their insurance to pay for it, or what the options may be there?
Sure, yeah. So typically, if someone meets NCCN criteria, so that for recommending genetic testing, most insurance companies follow that NCCN criteria more or less. Some companies like Cigna, their policy for genetic testing is if NCCN recommends it, then it's covered. UHC, United Healthcare, Blue Cross Blue Shield, Aetna, most insurance companies follow that more or less. Sometimes they have slight variations from that. So typically, if someone meets the criteria, then it'd be covered by insurance. The one caveat I always tell people is that it can be covered by insurance, but still someone could still have an out-of-pocket cost because of deductible or copay. So that's where it kind of can depend on their particular plan and if they met their deductible and things like that. The self-pay price, though, if the cost with insurance is going to be more than $250, the self-pay price with the labs that we use is $250. So for many people, that's going to be accessible. And the labs also have pretty generous financial assistance. So if you're someone who says $250, I don't know that I can cut that, there's probably financial assistance as well. And then also for anyone who's affected with breast cancer, one of the labs that we use is basically has a policy that if you're affected with breast cancer, there's no out-of-pocket cost. So if it's not covered by insurance, then they don't balance bill those patients. So there's also, and I'll add on to this too, that there is one group that the American College of Breast Surgeons who recommends genetic testing for anyone with breast cancer, regardless of the family history or age or anything like that. So that's definitely the direction it's going, is recommending testing for everyone.
Yeah. Can you comment? We had a question about at-home genetic testing. I think there's a lot of just information out there now with 23andMe and some of these commercial genetic testing kits. Do you have recommendations around that? Like what information that provides is different than what somebody might get when they come in for consultation with one of you in the genetics clinic, and just sort of in general, what recommendations or guidance around using those kind of at-home testing kits?
Yeah. So 23andMe and Ancestry are great for figuring out ancestry, where your ancestors lived 500 years ago or from 500 years ago, and finding family connections. But I would say not so good, not very good at all in terms of clinical genetic testing, especially as it relates to hereditary cancer risk. So what can get confusing is that I know that 23andMe, I believe Ancestry has a package like this too. They'll mention that they look for certain mutations in BRCA1 and 2. I believe they look for 3 specific mutations out of hundreds or thousands of specific mutations, just in BRCA1 and 2. So they're looking for just very specific mutations that are common in the Ashkenazi Jewish population. They're not going to report anything that's outside of those very specific mutations. And also their testing methodology, the way that they do the genetic testing, is very different than clinical genetic testing. In both cases, you can use a saliva sample, spit into a tube, but they're different underlying technologies. So even though, it's just a very different genetic testing. The way that they do it is different. So they can't have very good sensitivity for looking for mutations in genes, the way that clinical genetic testing was. So all of the short of that is, I would not at all rely on at-home testing for determining if there's a hereditary predisposition.
Cancer risk. Yeah, no, that makes sense. And I think I've certainly heard cases where something's been picked up, somebody's kind of been tipped off by a possibility of something being there based on risk or based on family history. But yeah, I think that there's a little bit of a misnomer there in terms of the what's available commercially and what we can do in an oncology sort of practice setting that's a little bit more specific to guiding risk. We had a question from somebody who says the new genetic mutations that have been discovered in the last several years, like what impact does that have? This is for a survivor who was tested about 8 years ago. How would she sort of navigate, like how often, or what's the recommendation for how often you might want to revisit genetic testing or genetic counseling with somebody who's been tested in the past, given that there are new developments and things have been reclassified, and sort of what is the guidance with that?
Yeah, that's a great question. It's a question we have often and we've been grappling with. It used to be that we would say, if you were tested more than 5 years ago, then consider retesting because there's new genes. But where there really haven't been new genes discovered, there haven't been many changes, over the past 8 years or so. So if someone had a panel genetic testing, so beyond BRCA1 and 2, most likely they don't need updated genetic testing. There can be variations that are found on testing that sometimes get reclassified. So if they have a variant that's uncertain, those can sometimes get reclassified. The best thing to do would be just to ideally try to find your test results and check to see if there's been any updates. Our office is, we try to notify anyone if there's been changes to their genetic test results or to the classification of variants. The vast majority of the time, things are being downgraded. It's pretty rare that things are being upgraded, where there's an inconclusive result that gets upgraded and now all of a sudden the lab thinks it's harmful. So it depends on what genes someone was tested for. But I would tentatively say if they had panel testing, you probably don't need updated testing.
Okay. And that may be something just, as a matter of following up with your provider, whether that's your oncologist, medical oncologist, maybe just make them aware of the test, make sure that they have that testing on, as part of the record, and then, and then ask, make that kind of an ongoing conversation and question to follow up. But yeah, I think the labs, if the testing was done through a lab, which, I mean, obviously the results would be that information would be updated as things are discovered. So really, I feel like the year was really like, if it was I know there's like certain years that we give, if it was like pre 2016, is that still kind of
I
the,
would say if someone was tested in 2013 or prior, they definitely should have updated genetic testing. 2014 through 2016 is kind of more of a gray area.
okay,
Most of the people that I've seen that have been tested in 2014, 2015, 2016, they were tested for everything or nearly everything. Sometimes there was a few genes that may have been left off, but they're more or less not as important of genes. They're like,
right.
50,000 people have a mutation in that gene. And some of those also are part of syndromes like neurofibromatosis that has more obvious signs and symptoms beyond breast cancer. So generally, I would say if they're tested in 2014 beyond with a panel beyond BRCA1/2, most of the time they're tested for most of the things.
Okay.
Or all of the important things.
That's great. Thank you. We had one more question. I think this will be the last one because we're already over time a little bit, but I just wanted to get this one in there about a person whose husband has a known BRCA mutation in the family and just the concern about their daughter's risk. So for that one, I think you've said this, but I think the ideal situation would be if the person who is affected by cancer in the family is still alive, to test that person. And then depending on the relationship, kind of like, whether it's first degree or second degree, kind of identifying risk in the child. But can you give, again, some, guidance in terms of father's side, known BRCA mutation, and kind of guidance for the family?
Yeah, so especially if there's a known mutation in the family, then I would say then the father being tested, if at all possible, would be greatly beneficial to see. If there's a known mutation, the child could do it, even without knowing if the father had it, because at least in that case, what you're looking for. But if you have 6 siblings, then just practically speaking, if your dad is willing to do the genetic testing, you may be able to eliminate the need for any of your siblings to do the genetic testing, grandkids and etc. So possible test them, but they could go ahead and test right away too, if they wanted to.
Great. Thank you so much. I feel like we've had great questions. I want to thank everybody for the interactivity and just the engagement. It's been another great session and discussion. I think just kind of following up from last week. I've connected with a few of you through chat. There were some specific individual questions. So I just want to make sure that y'all are fully aware that you can follow up with me directly, or you can also follow up with Tim. If you have questions about genetics, you can ask Tim or somebody else from the genetics department. Their email is genetics@northside.com, or you can call the phone number, which is 404-851-6284, and that's also in the chat. So if you want to just grab that information real quick. You can also reach out to the cancer support community and they can put you in touch with either of us. My information is also, happy to answer questions in email if folks have questions about, what sort of next steps or resources are available. And please just, if you're not already, please plan to join us next week on Thursday for session 3 of this series, which will be with Savannah Duffy, our dietitian, oncology dietitian. She will be talking about really what we can eat and how we can change our diet to impact risk and to reduce risk. So should be another great conversation. I just want to thank Tim, Hakim again for your time and knowledge and enthusiasm in this subject. It's just really great to hear from an expert. And I want to thank Katie Ormsby and the cancer support community team for bringing this program and this series to us. And just again to thank everybody for your time and your engagement, your questions. And if you have additional questions or concerns, please follow up with Katie at the Cancer Support Community, or me at Northside. I'm Emily Beard, and that's emily.beard@northside.com. Happy to have more dialogue about any of this with you, or put you in touch with the experts. So thank you all for your attention, and we'll hopefully see you next week. Take care.
Thank you for joining Cancer Support Community Atlanta for this program. If you're interested in other live or recorded programs, please visit the online program tab of our website, cscatlanta.org, or follow us on Facebook. We'll be sharing additional information on upcoming programs.